Can you hear?
Yes, sir. Yes, sir.
Yes, sir.
തുടങ്ങട്ടെ സാറേ, പെട്ടെന്ന് സാറിന് തിരക്കാം, രമേശ് സാറിന് തുടങ്ങാണേ.
Yeah.
Good evening. Good evening. IAP Kottayam is conducting its first academic activity on its own Zoom today as part of observing World Kidney Day. And now I invite our president, Dr. Joseph Patani, sir, for the presidential address. Sir.
Our vibrant and the most efficient and most active National President, Dr. Ramesh Kumar. Really, it's a pleasure to see you in the this laptop. State President-elect, our Dr. Kodur. See, you are held up in Kerala, so I did not. Dr. Professor Virendra was the most knowledgeable, one of the most knowledgeable professor of the era. Dr. Harish, consultant nephrologist, St. Thomas Hospital, Tittipura. Dr. Christy Kadri, pediatric nephrologist from PD Medical College, IAP. Our Dr. Past President D.S. Umar, sir. All senior members, Virendra is there. Then all senior members. I don't know, many of few people are missing to my mind, but most are. I'm really happy and here to present before you. And Dr. Rija, Dr. Manu, Dr. Sahila, all my senior colleagues. This is an important occasion for us. That is, our senior members have come to our CME. Even though World Kidney Disease was on March 10 yesterday, we are celebrating today only because of some problems. The theme of World Kidney Day, kidney health for all, build the knowledge gap to better kidney care. The incidence of chronic renal disease is about 1 in 10 below 68, 60 to 75, it is about 3 in 10, and above 75, it is about 50%. That is according to the credentials show. And I know the symptoms are either asymptomatic or maybe mild morbid edema of the face and limbs, and sometimes through the urine, urine, etc. Only last stage it may be anuria and so on. The diagnosis is simple: blood test as well as urine test. Urine albumin, microalbumin, or albumin, albuminuria, then albumin with the creatinine ratio, and simple blood test creatinine gram further. It comes about less than 1,000 rupees only. The people who are prone for renal disease are one the family history of kidney diseases. Those have got proteinuria family history. Then those are recurrent UTI, high BP, high diabetes, and 70% of the chronic renal disease comes in people who have hypertension as well as diabetes. The management actually supporting care as well as dialysis and end stage or transplant. But how the people are suffering. Suppose you develop chronic disease, it is simply to say dialysis or simply to say transplant, or how economic difficulty, financial difficulty, because most of our setup, the insurance is not covered. That was the most difficult problem. And I say, well, how do you prevent? We control hypertension, people say control of diabetes, keep good health, good active, and if we hit adequate hydration may be there, healthy food may be advised, avoid smoking, and avoid painkillers. This may be one of the important points you have to involve when you are talking about them. The main aim of World Kidney Day is that to promote our attention to the people, the awareness. We should make awareness. What is the problem? The chronic diseases are going to be the fifth killer in 2040. That's what the statistics show. So this is a small introduction. I should welcome our each and everyone here. I'm really thrilled to see Dr. Ramesh Margosi here on our own product, I should say our own product of Kottayam, and I really appreciate his presence here. Along with that, because of the way Ramesh Kumar is behaving so well, so soft. Anywhere he will leave the stage to see somebody, he so fine. And that is an acceptance. Sir, keep it up. We want you to come again to the World Pediatrics Department and World Organization to come up. I know we are here to see you in future also in the highest position. Your smiling itself keeps us energy, enthusiasm to work more. And regarding Ojo, actually, he's the president-elect. He's all. I have never seen him a little angry. Always smiling. Any issues he said, Parani, I will do it for you. That was the answer. So I am happy, sir. Then again, Dr. Virendra Kumar, I said the encyclopedia of pediatrics. Any question, any time in the night and day, when I ask, he answers, and he'll help us not only as a professor, and his wife is working along with me, a very nice lady, and probably we say the success maybe because of the lady behind in the scene, behind the scene as the Virendra was. Then going to the Kristi Kadar as well as Harish. You are well speaker, well known people. I know both of them indirectly, and I are happy in their presence actually. And all including Rali Maman, Dr. Piyush Sukumaran, all seniors. We are happy, sir. Please, we on behalf of IAP, I welcome you all of here. And this is how the interesting topics. I conclude because of the lack of time. Thank you, sir. Thank you very much. Thank you all the people all here. Priya.
Okay, thank you, sir. IAP Kottayam is privileged to have our IAP National President, Dr. Ramesh Kumar Asa, to attend this program. Sir started his journey as IAP State Secretary 2009 and 2010 and became National EB member 2011-12. Finally, he became Honorable Secretary General IAP 2018 and 19. He has been editor of many academic publications and books, and IAP Kottayam is really grateful to sir to join us in between his very busy schedule to grace this occasion. And sir, you can kindly inaugurate our Zoom. Sir.
Thank you, my dear Prija. And in fact, I am privileged to be with my team at Alumni Kottayam team, as well as my home branch, I should say. I'm a native Kottayam district only, and my roots and my academics, everything belongs to Kottayam, and my mentor and teacher, Sukumaran sir, who handheld me into IAP some 15-20 years back. So I owe and Dr. Jose and my intimate friends, Bala, all are there from Kottayam, Dr. Darli. So chair of the session, President IAP Kottayam, my beloved Dr. Patani sir, President-elect Indian Academy of Pediatrics, Kerala State Branch, Dr. Jose, my teacher, my mentor, IAP President 2011, Dr. Piyush Sukumaran sir, Vice President Kottayam Branch and Professor IECH, Dr. Darli, Secretary Kottayam, Dr. Prija, then Dr. Manu. Dr. Manu, I thought you are Balachandran sitting there. Actually, it is the same short Bala looks like, and Dr. Saliha, and of course the moderator, the great moderators, our dear teacher, Dr. Virendra Kumar sir, Dr. Jayaprakash, JP, and our speakers for the day, Dr. Harish. I'm so happy that Harish is around. The new gen is taking over. That's the message is clearly going. Dr. Harish and Dr. Kristi coming in place of Dr. Susan Udup and others. So the generation is coming up. So good to have you around. And my dear friends, all my dears, Dr. Jacob Matai and I can see all my friends in IAP Kottayam. Friends, this is a great moment for me to be, as I said at the outset, being at Kottayam, being with this team, give me, I'm sure, much needed positive energy and the kick to move to the Pedicon. Hardly a week, I'll be in Noida, and you will all be looking forward for the great event. I'm so thankful and so excited to see that Kottayam branch is moving ahead in the full academics year after year. And the key stalwarts, Dr. Sukumaran sir, those even if he's away from Kottayam, is all support Kottayam. The ICH team is there. Dr. Darli has been spearheading the activities and is very much with the organization right now. I'm so happy that she was our just joined senior, but it's always like good friends over the years. And seeing her, it gives me another great moments. And Prija, of course, they are also quite juniors, but so good to see. And with being at Kottayam is always something like coming back home. So then Patani sir told me about it. I said, I need some energy to be rejuvenated. So being with Kottayam could be the kick for me to go to Pedicon. So sir, thank you very much, sir. And I am so happy that he keeps always connected to me many a time regarding the academics. And we will see the great statesman in you coming up and showing off in the Kottayam branch, making it to a different level and setting a different benchmark this year, especially with the physical meetings could be happening around in the post-COVID era. We look forward to Sir Patani sir as well as Prija and the young thugs like Manu, Saliha, as well as all this supporting around with the guidance of Sukumaran sir and Mulel sir. And Jagama sir is I believe he's not joined. I didn't see, but sir is always another mentor for Kottayam team, Balachandran. And friends, this is a World Kidney Day. As sir said, I didn't have an occasion to join any meeting yesterday, but then I can really compensate for being with you here today. And I'm sure these young two stalwarts, Harish as well as Christy, I'm coming across them for the first time, Dr. Christy. Well, welcome to our fold and seeing them in our platform. With Dr. Joss around, I'm sure you'll be most visible in the IAP platforms hereafter. And this team will have a great academic session. And alongside, it's my privilege to welcome you all to the mega event coming up the IAP Arena, the Noida Pedicon from 19th. We have got a wonderful team. The resilience of the team has been superb. They have been working on this for 2.5 years. And a mammoth infrastructure, they are out there, more than 200 acres of well-built infrastructure, everything under one roof. Superb arena. You should come there to see what exactly is happening there. Some more than 35, 40 halls. Everything is done. You just go inside and you get from the restaurant to bar to the food and everything and academics on one side. Everything is done there. We just have to come and realize and we go out in the night, late night. You don't have to look for anything else. And the team there is such a vibrant team, such a forceful team. And with under Dr. Ruchira Gupta as well as Dr. Vineet Saxena, our HSG also as a chairperson. So that's, I'm so happy that this is the one place where I really, apart from Cochin or Kerala, in Kerala city, I would have really loved to be installed. And I'm sure you all being a part of who really trust the job on me, you should be there to bless me and grace me the occasion of the inaugural functional installation. And over the above, we have Dr. Sukumaran sir only delivering the prestigious Chandilal Seth oration in Pedicon. So that happens on Monday. So that is the prestigious event in the Indian Academy of Pediatrics Annals. So we are so happy, sir, that you are being selected for this oration, and I wish a great time with the oration and happening with you at on the dais for the Chandilal Seth oration. So it's a great time coming up. I wish each one of you to join or maybe bless us. Those who are not coming and perhaps may not be joining the conference for many reasons. But the exams, we really understand the exams are around, the children at home really have to push through, and then the COVID still not out. Many may be little apprehensive, but please bless all of us who are at the Pedicon and a great conference, pray for the great conference. And with all your blessings, and I'll be taking over next month, maybe on 20th, as a National President of Indian Academy of Pediatrics on a formal note. And I need all your support, continued support. It's not like it's happening over the years, but something such more energy and positive support, emotional support, maybe from you all for the function as the president. And I wish the CME as well as the ongoing activities in IAP Kottayam and the team led by our leader, Dr. Patani sir, as well as Prija and all that around, to have a wonderful academy year at the Kottayam branch for the year coming up. Thank you very much, and thanks a lot for the opportunity, Patani sir and Prija, and thank you so much.
Thank you, sir. Thanks a lot for the message and for the blessings. Next, we move on to our felicitation. Felicitation is our Dr. KP Deprakash sir. He needs no introduction. He is our vibrant and revolutionary superintendent of Kottayam ICH, who has done many good things after he took charge, especially the Miyawaki garden, which I have not seen, but we all would like to see. Sir has been IAP Kottayam secretary, and he was NNF president Kottayam 3 years back. Over to you, sir, for felicitation.
Most welcome, JP. I forgot to, I have not seen because light is left there in your room. Most welcome.
Thank you, sir. Thank you. Dear Patani sir, and our national president, Ramesh, who is my immediate senior, and teachers, Sumaran sir, VK sir, Darli madam, and other colleague, junior and senior colleagues, friends. See, World Kidney Day gives a unique opportunity for all of us, and it's more so with the Kottayam branch because the own Zoom meeting on such a day. This time, I'm reminded of one of my beloved teachers at Madras Medical College, M. Vijay Kumar, who's not with us. It just showed in pediatric nephrology department how many people, how many kids are not treated well for simple UTI and how they land up in MMC, ICH MMC. So he and Dr. Tamila Rishi was actually instrumental in getting many people to know more about pediatric nephrology. In fact, ICH had a pediatric nephrology textbook then. They had a medal exam then. They tried to percolate the idea of treating, having a good protocol for UTI, such an important topic for a pediatrician. I think among kidney diseases, one which you and me are that for that factor everybody is likely to treat is a UTI, and you have they have shown us you should be very aggressive in treating UTI. The SP urine we do aggressively in ICH now actually is a big promotion given by them. So we can save many people's kidney with our own way of aggressively treating at least a UTI, first UTI. I think the good protocols are coming up. IAP has given its own protocol. That's a nice thing to happen. I wish this will kickstart. This will give more thrust for pediatricians to look into simple problems like UTI. That's all I would like to say.
Thank you, sir.
Thank
Thank you, sir. Next, we'll go to our first session. It's follow-up of hydronephrosis in a newborn. And I invite Dr. Virendra Kumar, sir, former neonatology chief and additional professor, Kottayam Medical College. And he is presently working under NHM in the same department. And he has published many case reports and research papers in both national and international journals. Virendra Kumar, sir, is a reviewer of BMJ case reports. Over to you, sir.
Thanks, Dr. Prija. Good day, everybody, all IAPians. Good day. Let me first express my gratitude for giving me this opportunity for sharing this session for the IAP office bearers of Kottayam, Dr. Joseph Patani, Dr. Prija, Dr. Manu, Dr. Sakala, and all others. Thanks for kind words of Dr. Joseph Patani also. Today's first topic is hydronephrosis, follow-up of hydronephrosis in newborn. This is a very relevant and very practical topic for all pediatricians caring newborn babies, because this topic is selected in association with the World Kidney Day. One of the associated logos, even though the theme of World Kidney Day is kidney health for all, but one of the associated logo is bridging the gap in the knowledge to improve the kidney care. So this topic is very relevant, very practical. If you are seeing 100, 150 newborns, 150 deliveries every month, you will surely see 1 or 2 hydronephrosis, antenatal hydronephrosis. Surely you will see. Luckily, majority of them will regress at the time of delivery. Rest will regress in the infancy itself. But some of them will create real problems, especially severe oligoamnios, bilateral hydronephrosis, diagnosed early in the antenatal period. In the early second trimester, 20-24 weeks. Early diagnosis, gross hydronephrosis, that will create real problems. So it is a quite common topic. And also, follow-up is a very must, and follow-up should be well planned, and it should be scientific also. for reducing the mortality as well as morbidity. Today's topic is presented by Dr. Christy Catherine. She is a pediatric nephrologist from Government Medical College, Alappuzha. She was an alumni of Kottayam Medical College for MBBS. She did her MD from Government Medical College, Thiruvananthapuram, and pediatric nephrology DM from prestigious Institute of All India Institute of Medical Sciences. I'm welcoming Dr. Christy for giving the talk.
Thank you, sir, for those nice words. I will start sharing the screen. Respected teachers, am I audible? Dr. Preja, am I audible?
Yes.
Respected teachers, senior pediatricians, and IAP colleagues. My topic is evaluation and management of antenatal hydronephrosis. At the outset, I would like to thank the organizers for giving me the opportunity, especially Dr. Preja. I'm delighted and slightly tense to present in front of my teachers. I will go ahead with the topic. So our topic is evaluation and management of antenatal hydronephrosis. As Sir has already mentioned, it is quite common. It is a most common anomaly detected on routine prenatal ultrasonography, affecting around 1 to 4.5% of all pregnancies. And it constitutes around 30% of all congenital defect that is detected in antenatal scans. But luckily, 80% cases are mild and it may resolve. About detecting the hydronephrosis, the collecting system of the normal kidneys are usually not visualized. The hydronephrosis appear as a branching interconnected areas of decreased echogenicity, hypoechoic or anechoic or completely black. There is no universally accepted grading system, usually all classified as mild, moderate, and severe. So here you can see the pelvis of the kidney, which divides into the major calyces and then further divides into the minor calyces. So this is a normal kidney with the intact pelvis. So in the case of a mild hydronephrosis, here we can see an obstruction also. There the pelvic dilatation with mild dilatation of the major calyces. Here with the moderate hydronephrosis, the pelvis has further dilated with the dilatation of the minor calyces with the thinning of the medulla also. Here, the cortex has also started thinning. In the ultrasonography, here we can see the hypoechoic area or the black area, which is usually not seen in a normal kidney. So there is splitting of the pelvis and splitting, and there is hydronephrosis. This is further. There is medullary, it has encroached into the medullary area, and medullary thinning is there. And here you can see a very thin layer of the cortex and the cortical fin. The hydronephrosis is usually graded and classified based upon the pelvic anteroposterior diameter. This diameter is calculated in a transverse view, transverse plane with the at the level of the hilum, at the angle of the kidney, the anteroposterior diameter is calculated. As you can see, this is the anteroposterior diameter, and this will be used to classify or grade the hydronephrosis. So diagnosis and grading of antenatal hydronephrosis. It should be graded and diagnosed based on the anteroposterior diameter of the fetal renal pelvis. Antenatal hydronephrosis present, the APD is more than 4 millimeter in the second trimester, and if it is more than 7 millimeter in the third trimester. So this is the ISPN classification of the grading of the antenatal hydronephrosis. In the second trimester, if you have a more than 10 millimeter APD, it is classified as severe hydronephrosis. And in the third trimester, if it is more than 15 millimeter, it is graded as severe hydronephrosis. The another form of grading is the SFU classification. Usually, some of the radiologists give the report as the SFU grading. In the initial SFU grading or the grade 1, there is minimal splitting. In the second grade, there is major calyceal dilatation. And then the third SFU grade 3 indicate there is minor calyceal dilatation. If the parenchyma is thin, it will directly go to the SFU grade 4. There are other grading also, like the UTD grading, UTD classification, but that is slightly complicated. I'm not mentioning it here. So once we have identified that the patient is, the baby is having an antenatal hydronephrosis, we should go ahead for a detailed ultrasonography. Detailed ultrasonography, we should check the antenatal hydronephrosis is unilateral or bilateral. What is the grading? Whether the antenatal hydronephrosis affecting, there is a parenchymal thinning cyst, whether there is, what is the parenchymal echogenicity like, whether there is urinoma, what is the ureter look like, is there any dilatation or tortuosity, what is the bladder like, whether the bladder is distended, there is wall thickness, or there is a keyhole sign. Identification of the AFI is also very important. And at around 16 to 20 weeks, we should be, by the detailed ultrasonography, we should be able to identify whether there is obstruction. If there is obstruction, what is the level of the obstruction? If you see only pelvis is dilated, it may be a pelvic-ureteric junction obstruction. And suppose there is bilateral hydronephrosis with a ureteric dilatation and a thickened bladder, it may indicate a bladder outlet obstruction. So we have to check whether there is renal dysplasia also. Renal dysplasia we can identify by checking the parenchyma of the kidney, whether the altered parenchymal echogenicity is there, or there is thinning with formation of the cysts are there, that may indicate a renal dysplasia. We have to check for extrarenal anomalies also. The cardiovascular, neurological, gastrointestinal, and skeletal system should be screened by the ultrasonography. Soft signs which are described here also indicate that the hydronephrosis may not be isolated. It may be a part of the syndrome or some malformation. So moving on to the etiology of hydronephrosis, about 50 to 70% of these antenatal hydronephrosis are transient antenatal hydronephrosis, and the isolated hydronephrosis is also common. The etiology is usually established by the postnatal evaluation, and the importance is that the outcome depends upon the etiology. PUJ obstruction constitute around 10 to 30%, almost similar to that of vesico-ureteric reflex. PUV around 1 to 5%. Other rare etiologies include the neurogenic bladder, VUJ, multicystic dysplastic kidney, duple kidney, ectopic ureters, megaureters, urethral atresia, prune belly syndrome, and urogenital sinus malformation. So this is a posterior urethral valve. Here from the verumontanum, a thickening of the membrane arises, which anteriorly fuses and forms the obstruction. So after, because of this obstruction, the bladder will become thickened and constricted, or it may get dilated, and there will be secondary reflux to the kidney with parenchymal thinning and hydronephrosis. This is a keyhole sign with the thickened bladder wall, and the ureteric posterior urethral dilatation also seen in the image. About the vesico-ureteric reflex, it is when the myogenic mechanism that control the that prevent the reflux from the bladder into the ureter is damaged, there will be a reflex, and there are multiple pathogenic mechanisms postulated for the reflex, which one of this include the length of the ureter in the bladder musculature is decreased, that can lead to reflex. So this image showing the grades of the reflex, grading depend upon the extent of the reflex into the ureter or the extent of the dilatation of the pelvic calyceal system. So next common is the PUJ obstruction. You can see there is an obstruction with the intact ureter and intact bladder with the isolated dilatation of the pelvis along with the calyces and thinning of the cortex. So the algorithm for when you have a unilateral hydronephrosis, the follow-up algorithm is as follows. If the patient is having a unilateral hydronephrosis and no other malformation, we have to check the third trimester ultrasonography. If it is APD is more than 15 or the severe form of hydronephrosis, we can do the ultrasonography at 3 to 7 days of life. If the APD is more than 7 millimeter, it's like it is between the mild and moderate form. Ultrasound may be planned after 7 days. And if the patient is having mild dilatation of the pelvis, and the APD is less than 7 millimeter, you can wait for 3 to 6 months also. Then for the algorithm for evaluation of the bilateral hydronephrosis, once we have a bilateral hydronephrosis, we have to look for the danger sign. What's the important sign is the oligohydramnios at 20 weeks or the bladder volume more than 5.4 centimeter cube. These findings indicate that we have to anticipate a severe lower urinary tract obstruction, renal dysfunction, and patient is at a risk of perinatal mortality. There is no danger sign. You can do the serial ultrasonography monitoring for oligoamnios, and will be based on the gestational age of appearance of oligoamnios. In case of suspected bladder outlet obstruction, always we have to move ahead with the immediate postnatal USG. Otherwise, we can plan around 5 to 7 days. In case of presence of danger sign, we should also consider whether we should go ahead for an in utero management. This is the ERKNet Caput working group consensus or the management of lower urinary tract obstruction that should be followed. They classify the risk stratification based on the ultrasonographic findings, amniotic fluid, and the urine biochemistry. They classified into mild, moderate, and severe category. In the mild category, there is no evidence of renal dysplasia, and there is a normal fluid volume, no oligoamnios, and a favorable urine biochemistry. In the moderate group, we have oligohydramnios, and the renal dysplastic changes are not evident, and we have a favorable urine biochemistry. The severe form, we have the oligohydramnios, dysplasia is evident in ultrasonography, and the unfavorable urinary biochemistry. In case of moderate and severe, we can go ahead with a perinatal intervention if available. The prenatal interventions include their aim is to relieve the obstruction, allow normal renal development, maintain the amniotic fluid level to allow the normal lung development. The options include the vesicoamniotic shunt, surgical ablation of the valve, and serial amnio infusion. Vesicoamniotic shunt, after the amnio infusion, the patient fetus is kept under anesthesia and the shunt is placed. There is risk of PPROM and abruption. In case of surgical ablation, cystoscopy and ablation of the valve is done. And all these prenatal interventions are associated with perinatal survival, better perinatal survival. But the survival at 6, 12, and 24 months are almost similar. So the long-term outcome is still almost comparable with the control group. The consideration of termination in case of antenatal hydronephrosis should be only considered in case of extra-renal life-threatening abnormalities as per the guidelines. Postnatal evaluation is, postnatal evaluation, our aim is to find what is the overall health of the kid, what is the renal condition, what is the renal function and electrolytes, what is the status of the lower urinary tract, whether it is refluxing or obstructive, is there any presence of urinary tract infection or other complication, and to determine the etiology if possible. Postnatal ultrasonography should be done in those kids who had moderate to severe antihydronephrosis, but it has resolved in the third trimester. Still, in them also, we have to do the postnatal ultrasonographic evaluation. In the postnatal evaluation, the history should be taken on the severity of the antenatal hydronephrosis. Was there an oligohydramnios? Was it unilateral or bilateral? Clinical examination for extrarenal manifestations and blood pressure should be taken. Investigation should be done. Sorry about the urine analysis, RFT, electrolytes, proteinuria, and image. In case of a suspected bladder outlet obstruction, you have to mod it with the immediate evaluation. The bladder outlet obstruction you usually suspect in case of a bilateral hydroureteronephrosis, or in case of a single kidney with a severe hydronephrosis, a thick-walled distended bladder. The thickness is more than 2 millimeter, and especially in a boy child. We have to initiate the antibiotic prophylaxis, immediate postnatal ultrasonography, MCU, and go ahead with cystoscopy if indicated. For the postnatal evaluation, ultrasonography, the ideal, once we have ruled out the bilateral hydronephrosis or severe oligoamnios, then the postnatal evaluation ideally should be done in the 5th or 6th day. If it is more done earlier, it may be underestimate the presence of hydronephrosis. Even if the 5th or 6th day ultrasonography is normal, you have to repeat the ultrasound at 1 month. Or the ultrasonography done less than 7 days or the first week has found to have renal anomalies in around 50% of the cases. So it is necessary that we should repeat the ultrasound at 1 month. Again, we have to look for, is there an obstruction? If there is an obstruction, what is the level of obstruction? Is there a renal dysplasia? And the extent and severity of the involvement should be assessed. There are multiple grading systems or classification system for antenatal hydronephrosis. The SFU grading system, UTD, the ONN grading system are a few of them. So when you have a mild hydronephrosis as defined by the grading system, usually the ISPN or the SFU guidelines say like the AP diameter is 7 to 10 millimeter in the 3rd trimester, and there is persistent postnatal hydronephrosis. Good thing is that 70 to 98% of these group will have the resolution of hydronephrosis, or they may stabilize or improve during follow-up. The risk of VUR and UTI is negligible. It is around 3% only, and the risk of requirement of surgical intervention is also only 2% compared to the moderate and severe form. The follow-up is advised till 1 to 2 years, or till the patient is able to vocalize the symptoms. About the overall follow-up of postnatal evaluation of antenatal hydronephrosis. In the postnatal evaluation, if you are not finding any hydronephrosis, as I have already mentioned, repeat the ultrasound after 1 month. If it is still there is no hydronephrosis, you can leave the child. If the patient is having an SFU grade 1 to 2 or an APD of 7 to 10 millimeter, it is a mild form, so no antibiotic prophylaxis is needed. And we have to repeat the ultrasound at 1 month. Ultrasonography follow-up may be needed 4 to 6 monthly. If the patient is having an SFU grade 3, we have to give the antibiotic prophylaxis till the investigations are completed. MCU should be done initially. And if the patient is suspected to have a PUJ obstruction, we have to proceed with the diuretic renography, and the ultrasound should be repeated 3 monthly to check for the resolution or progression. So if you have the severe grade or the SFU grade 4, the APD more than 15 millimeter, initiate the antibiotic prophylaxis and first proceed with the MCU. If the MCU is showing VUR, then you have the reflex and manage like a reflex. If the patient is having no VUR and the patient is having a severe hydronephrosis, you can proceed with the diuretic renography. The diuretic renography is having an obstructive clearance and the need for surgery is satisfied, you can proceed with the pyeloplasty. If it is a non-obstructive pattern, or the surgery the criteria for the surgery is not classified, we have to follow up 3 monthly. There is the ISPN 2013 and other guidelines currently recommend antibiotic continuation at least till 1 year in case of reflux. In case of severe hydronephrosis due to other causes other than reflux, the guidelines differ in the opinion, and a few of the guidelines suggest antibiotic prophylaxis. Coming in detail about the uretropelvic obstruction or the PUJ obstruction. PUJ obstruction usually have a severe hydronephrosis. Mild hydronephrosis is present only in case of 8% and moderate hydronephrosis 23%. So most of them have severe hydronephrosis. If the patient is having a definitely APD is more than 30 millimeter, major calyceal dilatation more than 1 centimeter, and parenchymal thinning, and with no VUR of the patient, or if the patient is having SFU 3 or 4 with no VUR, we can go ahead with the diuretic renography. Diuretic renography will tell whether there is obstructive clearance or non-obstructive clearance. If the differential renal function is less than 14%, or there is serial follow-up if the renal function decrease more than 10%, we can consider pyeloplasty. Or in case of worsening hydronephrosis follow-up, diuretic renography has to be repeated. Presence of severe pain, palpable renal lump, or recurrent febrile UTI also, we can proceed with the pyeloplasty. About the vesico-urethric reflux, it is present in 1 to 2% of the healthy children is also having VUR. In case of an antenatal hydronephrosis, infants will have the hydronephrosis VUR is present in 8 to 38% of cases, and there is some genetic pathology attributed to the VUR. So siblings are found to be affected in case of 34 to 45% of cases. And in case of an affected child with a VUR, screening is recommended to the sibling by ultrasonography. If the ultrasonography is showing severe hydronephrosis, then only proceed with the MCU. By 12 years, in a febrile child, the incidence of VUR is around 10%. So that indicates there is a resolution of the VUR over time. One thing that we should note that in compared to the PUJ obstruction or other PUV, there is poor correlation between the grade of VUR and severity of hydronephrosis. A severe grade of VUR may present with a mild hydronephrosis. So when to do MCU? The MCU should be done in case of suspected bladder outlet obstruction, unilateral or bilateral hydronephrosis with severe grades, SFU 3 or 4, if the APD is more than 10, or in case of antenatal hydronephrosis with a ureteric dilatation or antenatal hydronephrosis presenting with a febrile UTI. When to give antibiotic prophylaxis, it's like you have a moderate to severe hydronephrosis while awaiting evaluation, or in a patient with a VUR infancy. Indications for surgery as per the guidelines include the lower urinary tract obstruction, UJ qualifying the criteria that I have already mentioned, or in case of a single kidney with a progressive pelvic dilatation. So MCU, I've already mentioned, it can detect the VUR, posterior urethral valve. But it is should be done with the placement of the bladder. But we should note that the radiation exposure is quite high. The other the test that can replace the MCU is the DRC. Advantage of DRC is that since continuous monitoring is there, the filling phase reflux can also be detected in case of diuretic radionuclide cystography. It is more sensitive to detect a reflux, but it gives poor anatomical details. DMS is a static cortical renal scintigraphy. Integrity of the renal parenchyma can be assessed by this test. It can give the differential function, the normal functional kidney, presence of can be detected, cortical renal scars, and if it is done at the time of UTI, it can detect the pyelonephritis. Radiation dose is equivalent to 20 to 50 chest X-ray. The diuretic renography with the DTP assess the dynamic renal scintigraphy. It can assess the drainage, whether it is obstructed or non-obstructed, and it can give the differential function also. Here you can see the DMSA showing the right kidney, the normal contour, and the uptake is maintained, and the left kidney, you can see the uptake is there are photopenic areas suggesting a scar. most likely it is a scar. Here, this is a DTPA where there is radioisotope uptake and there is non-obstructive clearance of the radioisotope. So here there is retention of the radioisotope, and while we are giving the furosemide, still it is retained. That indicated obstructive clearance. Here it is retained, the dye is retained by the kidney, but when we are giving the furosemide, it is excreted. That indicate it is not an obstructive clearance if the retention is due to the dilatation of the pelvis only. So I will conclude the antenatal hydronephrosis commonly encountered in the pediatric practice. Most are mild and may resolve. A systematic approach may unravel the in those who have the persisting hydronephrosis. The risk-based approach is currently followed, but the investigation like the MCU or the DTPA is liberal as per the current guidelines. Thank you.
Thank you, Dr. Prija, Dr. Christy, for the excellent presentation. It's a very wonderful presentation, and you covered the topic in detail without any doubts. In the chat box, there are no questions seen. Shall I ask one question? Oh, sorry. Dr. Nisha Krishnan asking, any centers doing antenatal surgeries, antenatal therapy for antenatal hydronephrosis? What is your experience?
Sir, I have no experience. I think it's in Amrita, some intervention is done, and in some centers in Chennai, these interventions are done. I have no experience. I have not done any till now.
Among the antenatal intervention for post-urethral valve, which is better, vesico-amniotic shunt or this fulguration valve?
Prenatal intervention.
And antenatal intervention for post-urethral valve.
The prenatal fulguration will be technically challenging. As I have already mentioned, the studies are limited, and whatever evidence we have is like both will increase the perinatal outcome, but the long-term outcome is poor. But I don't remember any comparative studies between the vesico-amniotic shunt and the direct fulguration. I don't know if Dr. Harish is knowing, he can share the opinion.
And another question from the chat. Yes.
So actually, there is not much. There's not studies comparing this shunt and fulguration. I don't know. As Christy said, there is no direct head-to-head comparison between these two. But anyway, the long-term prognosis in both cases actually not very good. The kidney functions, the comparison between these two, the kidney functions or the improvement in the function is not compared directly, or enough studies are not available.
Okay. One more question: at what age MCU done? At what age MCU done? I think that is covered in the topic itself.
In case of a bilateral hydronephrosis and you are anticipating a bladder outlet obstruction, there is no point in waiting. We can immediately do whenever it is possible, or you can, if the patient is having, we are just to know in a severe hydronephrosis, just to know whether there is VUR, or before proceeding with the diuretic venography, you have to do an MCU. You can do it 4 to 6 weeks. It depends upon the whether we are suspecting a PUV or not.
Any role for microproteins, serum microproteins, beta-2 microglobulin over classical RFT by creatinine and urea in the first week of neonatal life for assessing the renal function?
Beta-2 microglobulin. Okay. Renal function. Beta-2 microglobulin is usually.
Because creatinine is reflected by the maternal creatinine will reflect the serum creatinine in baby?
Cystatin C can be used, but I don't know about the beta-2 glycoprotein.
No,
Beta-
beta-2 microglobulin, actually, it is not actually regarded as considered as a renal function test. Actually, cystatin C can be used, but it is also not validated in a newborn child. But maternal creatinine will reflect only for 3 to 5 days. After that, we can measure the creatinine itself. So there is I don't think there is no studies regarding beta-2 microglobulin for assessing the renal functions. Cystatin C is actually an approved one, but that is also in neonates. I don't know whether we can do a cystatin C or not.
No other queries from the chat. No other queries from the chat.
Okay.
Thank you, sir.
Thank you, sir. Thank you, Dr. Christie. We will move on to the next session. And the moderator is our Dr. Jose Oster. He needs no introduction as he's known as the Josh of IAP Kerala. And he is the president-elect Kerala IAP. And as well as he is a Kerala State EB member. He is Central IAP Secretary of PAI and Associate Professor, Pediatric Department, Alappuzha Medical College. Over to you, sir.
Thank you, Priya, for nice words. I think IAP Kottayam, led by Joseph.
Sir, not audible, sir. Sir, കേൾക്കത്തില്ല.
Audible to.
Okay, sir.
Is it audible?
Yes, sir.
So, congratulations to the IAP Kottayam branch, taken an initiative to conduct a series of CME program on World Kidney Days. As already discussed, today, this year, the World Kidney Day theme, the kidney health for all. So there is importance of identification of antenatal problems of kidney disease and the postnatal interventions in the kidney disease. And another important topic is by identification of UTA and how the general practitioners know basics of treatment guideline for urinary tract infections. I think Joseph Patani sir and Dr. Pija and IAP Kottayam team, Dr. Darley, Dr. Manu, and all the Dr. Balajinder, Dr. Sumana sir, and all doing a wonderful IAP activity for this year, 2022 years. To talk with already we had another important topic by Dr. Christie. It was an excellent presentation, very beautiful narration of how to approach a child with antenatal detection of hydronephrosis. What are the interventions we can do in our daily practice to tackle the antenatal hydronephrosis in the postnatal life. Another important problem you have come across in the day-to-day practice, urinary tract infections. As you know, there is a lot of guidelines to how to treat a child with urinary tract infections. And even though there is a standard guideline is there, again, still there is a confusion when you have to investigate a child with recurrent UTA, and how will you proceed with a child with recurrent UTA? What are the interventions you have to do done early to prevent the kidney damage in the later life? To talk on this guideline for urinary tract infection general practice, to talk on the topic, we have another important expert in this field, the dynamic pediatric nephrologist. He is our own student, Dr. Harish from MBS from Kottayam, and he has completed his MD from Precious Institute, SAT Trivandrum, and he is completed his MD DM nephrology from German Institute Medical College, Trivandrum. After his he got a lot of awards. One important award he's received is he received a gold medal for best outgoing student MD pediatrics in German Medical College, Trivandrum. And after his completion his DM nephrology, he worked as assistant professor in pediatric SUT Medical College in Trivandrum, and also he's joined in health service in 2014 to 2015. After that, he's joined, presently working as a senior consultant nephrologist at St. Thomas Hospital, Chitipura, and St. Gregorius Medical Mission Hospital, Parimala, from 2019 onwards. He was very interested. He has a professional passion in renal transplantation and intervention nephrology and glomerular nephrosis. and he's he's a young, energetic pediatric nephrologist in Kerala. And with this ways, I invite Dr. Harish to talk on what is the common guideline to practice in the general practice to deal with the urinary tract infection children. Over to Dr. Harish for a presentation of the topic.
Okay. Thank you, Jose sir, for the nice words. Am I audible?
Audible.
Am I audible?
Yes.
Yeah.
Audible.
Okay, okay. I will share my screen now. Is it visible?
Yeah.
A very good evening to my respected teachers, senior IAP members, and my colleagues. At the outset, I would like to thank IAP Kottayam for this wonderful opportunity. And for this Kidney Day celebration, IAP Kottayam has selected two important topics in nephrology for discussion. The first one was antenatal hydronephrosis and its follow-up. And thank you, Dr. Christie, for the wonderful presentation and excellent narration of antenatal hydronephrosis and its follow-up. And the second important topics in our day-to-day pediatric practice is urinary tract infection. So urinary tract infection is a very, very important as a topic in pediatrics, because in day-to-day office practice, we are seeing a lot of urinary tract infection, and early detection and management of this urinary tract infection is very, very important, because it can lead to long-term complications like renal damage, growth retardation, and hypertension. And all these complications can occur due to a simple urinary tract infection in the developing kidneys. So it is very important to identify the urinary tract infection early, as well as to treat and follow up these children. So coming on the incidence of urinary tract infection, in less than 14 years of age, the incidence is 1 to 3% in boys and 3 to 10% in girls. And most of the time, a urinary tract infection is missed, because the child will come with the fever. Sometimes especially in the period of this pandemic, we will initially suspect a upper respiratory tract infection. Or sometimes we give an antibiotic without checking a urinary. So most of the time, if we are looking very keen, but we will miss a urinary tract infection. So most of the time, the infection will recur. Most of the time, after 2 or 3 infection, we will detect the urinary tract infection. What is the problem in delaying the diagnosis of urinary tract infection? Because a delay in the diagnosis of urinary tract infection can lead to an irreversible long-term damage to the growing kidney. In an adult, sometimes a urinary tract infection or pyelonephritis may not cause a permanent damage to the kidney, but a developing kidney or a growing kidney, it can result in a severe damage and long-term scarring, and which will result in hypertension and renal insufficiency in the later age. So rapid evaluation and treatment of urinary tract infection is the most important thing. So this is actually the crux of this topic. So the major points to remember in patients with urinary tract infections are: the urinary culture, the correct collection of the urine culture is the most important thing. And diagnosis of urinary tract infection is based on the positive urinary culture, not based on the urinary alone. It is based on positive urine culture. And patients with the UTI should be evaluated for the presence of complications and underlying anomalies or voiding dysfunction. That is also very important. And recommendations on imaging and follow-up of the first episode of UTI should be strictly followed up, because if we don't evaluate the cause of the recurrent UTI, sometimes even with a proper management of a single episode of UTI, the patient can come again with a recurrent UTI, and that can lead to complication like renal scarring and long-term chronic renal disease. So how will you define a urinary tract infection? Infection of urinary tract is defined by the growth of a significant number of organisms in a single species in urine culture with the presence of symptoms. That is the definition of urinary tract infection in a child. That a urinary tract infection can be a simple urinary tract infection or a complicated urinary tract infection. Simple urinary tract infection means UTI with low-grade fever, dysuria, frequency, urgency, and absence of symptoms of a complicated UTI. The symptoms of a complicated UTI means fever more than 39 degrees Celsius, systemic toxicity signs, vomiting, dehydration, renal angle tenderness, and altered renal function test. These are the features of a complicated urinary tract infection. If these features are not present, we call it as a simple urinary tract infection. Recurrent urinary tract infection means recurrence of symptoms with a significant bacteria in patients who have recovered clinically following a treatment. That is, after completely recovering from the infection, another infection is coming. It is called a recurrent infection. So, by definition, a significant bacteriuria is a colony count more than 10⁵ per ml of single species in a midstream clean catch sample. And asymptomatic bacteria is significant bacteria in the absence of symptoms of UTI. And the distinction between an upper UTI and a lower UTI is not very important in pediatric practice, because it is not. It is very difficult to identify an upper urinary tract infection and lower urinary tract infection, and it is not necessary for the management also, because anyway, even if it is an upper urinary tract or lower urinary tract, we have to treat and we have to follow the guidelines. So the distinction between upper and lower urinary tract infection is not necessary in the pediatric practice. So how will you diagnose a urinary tract infection in the office practice? The major, as we know, the major symptoms are fever, dysuria, urgency, frequency, flank pain or abdominal pain, especially in older children. Infants or young children will not complain of flank pain or abdominal pain. Fever, vomiting, diarrhea, and poor weight gain, and even jaundice, especially in newborns, it can present with even jaundice. And young infants, it's with the fever, vomiting, diarrhea, and poor weight gain. And along with this we'll have some investigations. Positive districts test for leukocyte esterase or nitrate, abnormal urine analysis with the significant pyuria and bacteria. And the most important thing is isolation of a single species of organism in a midstream catch. That is the gold standard of diagnosing urinary tract infection. All others are supportive. The gold standard is a positive culture in a midstream sample, or even a suprapubic aspiration or a catheterized sample. And asymptomatic bacteria is significant bacteria in the absence of pyuria or symptoms, and more common in girls than compared to boys, and is usually associated with non-virulent E. coli. And ideally, the importance of this asymptomatic bacteria is always asymptomatic bacteria always may not warrant a treatment. So diagnosing an asymptomatic bacteria is also very important. And significant bacteria is defined by the type of collection. In a suprapubic aspiration, any number of colony is diagnostic of a significant bacteria. And after catheterization, a more than 10⁴ count is diagnostic of a significant bacteria. And the midstream void sample, it is more than 10⁵ colony count. That is very important. Suprapubic aspiration, any number is considered to be a positive culture. And the common pathogens include most of the cases, more than 70% of cases, the Escherichia coli or E. coli is the organism, and other cases, 30% cases, even non-E. coli bacteria or even fungi can be detected. So the most important organism is E. coli, then Klebsiella and other gram-negative organisms. The more than 70% of cases, it is E. coli. And ideal sample collection for urine culture for toilet trained children, midstream sample can be collected, and it is the most preferred one. It is a non-invasive and practical method. For non-toilet trained children, we can have this simple urethral catheterization or a suprapubic aspiration. Both these can be used, but toilet trained children always preferred a midstream sample because it is the most non-invasive method for urine collection. And for a suprapubic collection, any number, I already told you, for suprapubic collections, any number of pathogens is any number of pathogen count is important. It gives a 99% probability of infection. For urethral catheterization, more than 10⁵ to 10⁴, it's 95% probability, and midstream sample more than 10⁵, it gives around 90 to 95% of probability for an infection. And for the initial evaluation, initial management and evaluation of patient with the urinary tract infection, all the patients should be examined for the severity of toxicity when a patient comes with a urinary tract infection. Always assess the degree of hydration, that is, his patient is dehydrated or not, or ability to take oral feeds. That is also very important. Otherwise, we have to give IV fluids. So assess the dehydration and assess the ability of the child to take oral feeds. And the blood pressure should be recorded, and the history regarding the bowel and bladder habits should be also elicited at the time of evaluation. And regarding investigations, after sending a urine routine and urine culture, we have to do a complete blood count, RFT, blood culture, because blood culture is very important, because it can usually child can present in a urosepsis. So blood culture is also very important, and especially in infants, we have, and patients with a suspected complicated UTI, we have to do a blood culture also. And child should be examined for the features suggestive of underlying urological abnormality also. We will come to that later. And major features which suggest a urinary tract abnormality includes a distended bladder, palpable or enlarged kidneys, tight phimosis or valvulus synechiae, palpable fecal mass in the colon, patulous anus, neurological deficit in the lower limb, urinary incontinence, and previous surgeries of the urinary tract, and anorectal malformation or meningomyelocele. All these, if all these are present, any one of these is present, it suggests a urinary tract abnormality, and that may be the cause of a recurrent urinary tract infection. And features suggestive of a bladder bowel dysfunction include recurrent urinary tract infection, personally high-grade vesicular reflex, constipation, impacted stools, and maneuvers to postpone the voiding like holding, squatting, etc., and voiding less than 3 or more than 8 times a day, straining or poor urinary stream, and thick bladder wall more than 2 millimeter, and post-voidal residual volume more than 20 ml, or spinning top configuration of the bladder on micturating cystourethrogram. All these suggest a bladder bowel dysfunction. So all these should be assessed in the initial evaluation of the child. And when we get a patient with first episode of UTI, the aim is to identify the patient is at a high risk for renal damage or not. And we should assess if there is a VUR or urinary tract obstruction. This is the first aim of a patient with the patient for evaluation of urinary tract infection. And the evaluation include, as we all know, we should do a ultrasonography, DMSA scan, and micturating cystourethrogram. All these should be judiciously performed. For all the children, we should not do all these things, but we should judiciously select the investigation or the imaging studies according to the age and presentation of the child. And the recommendation is all infants with UTI be screened by ultrasonography followed by MCU and DMSA. That is less than 1 year. All children should be screened by both all these 3 investigations like ultrasonography, MCU, and DMSA scintigraphy. And 1 to 5 years USG followed by DMSA. And if anything is abnormal, we should go for a MCU. And older than 5 years should be screened by an ultrasonography, and further evaluation is based on this ultrasonography. If it is abnormal, we have to go for a MCU and DMSA scan. So depending on the age of the child, you should select the investigation judiciously. And by ultrasonogram, we should assess the kidney size, the number and location, the presence of hydronephrosis, and urinary bladder abnormalities and post-voidal residual volume. And ultrasonography should be done soon after a diagnosis of urinary tract infection. We don't have to wait for 2 or 3 weeks to do an ultrasonography. We should do immediately after detecting a urinary tract infection. And DMSA scintigraphy, detecting renal parenchymal infection and cortical scarring. The DMSA scan is usually carried out 2 to 3 months after after subsiding the urinary tract infection, because sometimes it will take 2 to 3 months to develop the scar. But the early DMSA scan can be done to detect the pyelonephritis, but it is rarely performed, and it is not recommended in routine practice, because the photopenic area can be detected in even acute pyelonephritis, but it is not recommended to diagnose an acute pyelonephritis. So it is used mainly to detect a renal scarring. It is a static scan. DMSA scan is used for detecting the renal scar, usually done 2 to 3 months after the treatment of urinary tract infection. And the MCU scan, and Dr. Christie has already mentioned the details of MCU scan. It detects a viewer and provides anatomical details regarding the bladder and urethra, and it will give the grade of the reflex. And follow-up studies in patients with viewer can be performed by direct radionuclide cystography also. That is also explained by Dr. Christie. So follow-up the MCU. This MCU is an invasive investigation. So radionuclide cystography can be also done, but actually in our follow-up, most of the children are followed by the MCU itself, MCU ultrasonography itself. So MCU is recommended 2 to 3 weeks after an urinary tract infection, because at the time of infection, but avoid MCU because it can cause a retrograde infection extending into the kidneys. So MCU should be avoided at the time of active infection. MCU is usually done after 2 to 3 weeks of subsiding the infection. So the DTPA scan and MACD scan, patients showing hydronephrosis in the absence of VUR. That is, as Christy already told, the PUJ obstruction and obstructive flow can be detected in a DTPA scan, and a split renal function is also we can detect by DTPA renogram. So it provides a quantitative assessment of the renal function, split renal function, and drainage of the dilated collecting system, whether it is an obstructed flow or a non-obstructive collecting system, we can detect by DTPA, diuretic DTPA renogram. So that is also very important. So in a nutshell, this is the algorithm showing the evaluation of child with UTI, age less than 1 year, ultrasonography, micturition cystourethrogram, and DMSA renal scan. 1 to 5 years, ultrasound and DMSA scan. MCU is if ultrasound or DMSA scan is abnormal, and age more than 5 years, ultrasound. Initially, we do an ultrasound. If anything is abnormal, we'll proceed with the MCU and DMSA scan. And after evaluating this, we need a treatment for the child. Immediate treatment is after sending the culture and initial investigation, we have to start the treatment immediately. Children less than 3 months of age and those with complicated UTI should be hospitalized and treated with the parenteral antibiotics. That is very important. Less than 3 years and with the complicated UTI, hospitalization and IV antibiotics is necessary. And the first antibiotic we prefer is the 3rd generation cephalosporin. And therapy with a single daily dose of aminoglycoside is also used in children with a normal renal function. And intravenous therapy is given for first 48 hours and followed by oral antibiotics if there is very good clinical response. If there is no clinical response, we should change the antibiotic after getting the culture, or we should continue the same antibiotics till the culture is available. So initially, if there is a very good improvement in first 48 hours, we can change to oral antibiotics. And these are the common antibiotics which we prefer in treatment of UTI in children. Oral antibiotics include cefixime, amoxicillin clavulanic acid, cephalexin, and ceftriaxone. And we know the dose of each drugs. The parenteral antibiotics, 3rd generation cephalosporin is the preferred one, ceftriaxone and cefotaxime. And amikacin or gentamicin, aminoglycosides like amikacin or gentamicin can be also used as single daily dose. And for prophylaxis, we prefer quatrimoxazole, trimethoprim, nitrofurantoin, and cephalexin or ceftriaxone. And the duration of therapy, 10 to 14 days for infants and children with a complicated UTI, and 7 to 10 days for uncomplicated UTI. And adolescents with cystitis, shorter duration.
Some problem with this connection.
Prija, Harishna connection പോയോ?
പോയെന്ന് തോന്നുന്നു സാറേ. വിളിക്കാമേ സാറേ? കറണ്ട് പോയി സാറേ അവിടെ. ഷെയർ ചെയ്യാൻ പറ്റുമോ?
അല്ല, വീഡിയോ ഇല്ലാതെ സംസാരിക്കാൻ വീഡിയോ ഇല്ലാതെ സംസാരിച്ചാലും മതി.
ഇല്ല, കംപ്ലീറ്റ് പോയി സാറേ. നോക്കാം സാറേ. കേറുവാന്ന്, മൊബൈലിൽ കേറുവാന്ന് സാറേ.
ഓക്കെ.
Sorry for that delay. അവിടെ വീട്ടില് കണക്ഷൻ പോയപ്പോഴത്തേക്ക് കംപ്ലീറ്റ് സിസ്റ്റം പോയെന്ന്. കറണ്ട് പോയപ്പോ നെറ്റ് കണക്ഷൻ വൈഫൈ പോയി. വൈഫൈ കണക്ട് ചെയ്യാന്ന് സാറേ. ഇപ്പൊ കേറുന്നേ. കേറിയിട്ടുണ്ട്.
You can share now.
Unmute ചെയ്യണേ ഹരീഷേ. Unmute ചെയ്യണേ.
Sorry, my Wi-Fi is disconnected due to power failure. Sorry for the interruption. Okay. I will share my screen now. Visible? Is it visible now?
Yes.
Visible.
Okay. Okay. So the prevention of recurrent UTI, it's also very important. Recurrent UTI, as I already mentioned, recurrent UTI can result in renal damage. So prevention of recurrent UTI is very important. So the proper evaluation and the detection of the bladder bowel dysfunction, urinary tract abnormalities is also very important. And more than that, we should, till the evaluation is completed, we have to give antibiotic prophylaxis for these children. The indication and duration of this prophylaxis: any UTI below 1 year of age, while awaiting an imaging studies, we should give prophylaxis. And in case of VUR, we should give prophylaxis. And frequent febrile UTI, 3 or more episodes in a year, even if the urinary tract is normal, we should give antibiotic prophylaxis. And antibiotic prophylaxis is not advised in patients with urinary tract obstruction, like posterior urethral valves and urolithiasis and neurogenic bladder, because in these patients, it can result in antibiotic resistance. So antibiotic prophylaxis is not advised in patient with a urinary tract obstruction. So below 1 year, anyway, child need antibiotic prophylaxis, VUR, and frequent febrile UTI. Even in the absence of urinary tract abnormalities, we need a prophylaxis. And antibiotic prophylaxis for UTI, as we know, the major antibiotics which we use are cotrimoxazole. The dose is 1 to 2 milligram per kg per day, the night dose. Nitrofurantoin is also 1 to 2 milligram per kg. And cephalexin, usually 10 milligram. And ceftriaxone, it's around 5 milligram. As a rule, it is around 1/3 to 1/5 of the dose of the normal treating dose we give as a single nighttime dose. That is the rule of thumb for giving a prophylaxis. 1/3 to 1/5 of the dose we give as a single dose. That is, these are the major antibiotics which we use in prophylaxis of child with the recurrent UTI. And these are the indications for referring to a pediatric nephrologist: recurrent urinary tract infection in spite of the treatment, and urinary tract infection in association with the bladder bowel dysfunction, and patient with the vesicular reflex, underlying urological or renal anomalies, children with a renal scar, and deranged renal function and hypertension. These are the indications for referral. And this is the nutshell for treating a child with UTI. For uncomplicated UTI, that is age more than 3 months, non-toxic child with accepting oral feeds, we should start oral antibiotics. And if there is clinical improvement in 48 hours, we can continue the treatment for 7 to 10 days. If there is no response, we have to change the antibiotic, or we have to give IV antibiotics. And do not repeat a urine culture if there is good response. We can do a urine routine examination, but do not repeat a urine culture if there is very good clinical response. And all these children should have a further evaluation. And as I already told, less than 1 year, all the investigations should be done. 1 to 5 years, depending on why we should do a ultrasonography and a DMSA. And if something is abnormal, we should do an MCU. And more than 5 years, we do a ultrasonography. If ultrasonography is abnormal, we'll proceed with the DMSA and MCU. And for complicated UTI, that is less than 3 months, or fever more than 39 degrees, sick-looking child, dehydrated child, child not taking oral feeds, and there is renal angle tenderness and elevated serum creatinine, we should hospitalize the patient to give IV fluids, start IV empirical antibiotics, preferably a third generation cephalosporin, and watch for improvement in the first 48 hours. If there is improvement in first 48 hours, we should continue antibiotics. And if there is no improvement, we should follow up the cultures, and depending on the culture, we should change the antibiotic according to the culture and sensitivity. And if there is good improvement, we should continue antibiotics. We should change to antibiotic to oral antibiotics, and the total duration of treatment is 14 days for a complicated UTI. And for recurrent UTI, that is more than 2 episodes of febrile UTI, or more than 3 episodes per year. And a first episode of UTI less than 6 months of age, all these should be evaluated properly, and all the patients should be assessed for a bladder bowel dysfunction, and ultrasound of the abdomen and kidney and urinary bladder should be taken. DMSA scan and MCU scan should be performed, and these patients should be started on prophylactic antibiotic. And prophylactic antibiotic is indicated in the following patients: that is pending complete radiological evaluation after first episode of UTI, grade 1 or 2 reflex for the first 1 year, then grade 3 or more reflex for the first 5 years, and patients with the bladder bowel dysfunction and urinary tract abnormalities, the antibiotic prophylaxis should be continued till the abnormality is corrected. That is either bladder bowel dysfunction or the urinary tract abnormality is corrected. We should continue the antibiotic prophylaxis. And all the children with recurrent UTI should be followed up properly. Yearly should be followed up, and document normal urine analysis at the end of the treatment is very important. And do not need a urinary culture after complete treatment. If there is a breakthrough UTI, we can on prophylaxis we can do a culture and document the urinary tract infection. And periodic monitoring of the growth is also very important. Periodic monitoring, because child with reflex nephropathy and recurrent UTI can have a growth retardation. So periodic monitoring of the growth is also very important. And the blood pressure evaluation is also important. Every 6 to 12 months, we should evaluate the blood pressure, because child with early scar nephropathy or reflex nephropathy can have initial presentation can be hypertension. So blood pressure monitoring is very important. assess the renal functions once a year in child who had severe complicated UTI and recurrent UTI. That is also very important. Sometimes this renal dysfunction can occur even in later life. And I have seen patients coming first time during the pregnancy, that is in 20s, due to a reflex nephropathy. So the patient may not have detected the childhood UTI or identified the childhood UTI, and the first time urinary tract imaging is done during pregnancy. So the presentation can be in 20s or 30s. So it is very important to assess the renal function yearly in child with recurrent UTI, and always watch for proteinuria after a successful treatment of UTI. And it should be, if it is associated with the pyelonephritis and renal scarring, that is also very important. Renal scarring can result in proteinuria and hypertension, and later it can leads to chronic kidney disease. So VUR patients should be followed up with the serial ultrasonography while awaiting resolution. So even we can do a radionuclide cystography also for follow-up of VUR. And as already Dr. Christie said, siblings of patients with the VUR is at a high risk of developing VUR because it has a very strong genetic predisposition. So siblings of patients with the VUR should be screened by ultrasonography, and children with the renal scars needs long-term follow-up on yearly basis for growth, hypertension, proteinuria, and renal size and renal function. So the take-home messages are: early diagnosis of UTI is very important. A misdiagnosis can lead to renal scarring, hypertension, and chronic kidney disease. And the urinary tract infection diagnosis is mainly based on, or the gold standard for diagnosis of urinary tract infection is urine culture and sensitivity. And early initiation of treatment is very important. In children with complicated UTI, always admit the patient in the hospital and give IV antibiotics, and followed by, if there is good response, we can change to oral antibiotics. Age-wise evaluation and imaging is very important. We should use the imaging modalities very judiciously. We should not do all the investigation, all the child with the UTI. We should, according to the age, we should use it judiciously. And identification of risk factors is the most important thing in preventing recurrent UTI, especially the bladder bowel dysfunction and the urinary tract abnormalities, especially urinary tract obstruction and VUR is very important. And based on this, we will give prophylaxis and we will follow up the child. And antibiotic prophylaxis is very important in patients, in children with urinary tract infection, recurrent urinary tract infection, because antibiotic prophylaxis will prevent further infection, and which will prevent the kidney damage or the scarring and later development of a reflex nephropathy. And in children with reflex nephropathy, in children with a recurrent UTI, a long-term follow-up is very important, because these children can have hypertension, renal scarring, and proteinuria. So long-term follow-up with monitoring of hypertension, proteinuria, and renal function and growth is very important. So the management of urinary tract infection is very important in children, because the long-term complications are very cumbersome. So long-term complications are very dangerous in patients with a developing kidney or a growing kidney. So with this, I will complete my presentation. Any queries?
Thank you, Harish, for a very beautiful, very enlightening presentation of what we had to do.
Not audible.
Is it audible?
Is
it audible? Is it audible?
Yes.
Okay, sir.
Is it audible?
Yes, sir. Yes, sir.
Okay, sir.
So, congratulations, Dr. Harish, for a beautiful and simple way presenting how the pediatrician to identify urinary tract infection in children. What you had to do for the child once you diagnose UTI in a children with the first UTI or subsequent recurrent UTI, what you are supposed to do. So, congratulations to Dr. Harish. And we have some queries in the chat box. One query is from Dr. Virendra Kumar is, what is the role of cyclical antibiotic prophylaxis? Harish, can you stop sharing?
Yes.
Stop sharing?
Sir.
Stop sharing screen.
Sir, I can see that. Okay. Oh, now I can see, sir.
What is the role of cyclical antibiotic prophylaxis?
Actually, there is a two type of prophylaxis we can give. Continuous prophylaxis. Actually, we prefer a continuous prophylaxis till the urinary tract infection. Actually, the imaging or all the investigations are completed. Actually, we after the first episode of UTI for children with grade less than 1 year, we'll continue the antibiotic, continuously complete the antibiotics for 1 year, and till the urinary tract infection is urinary imaging is completed.
Okay. So, what to say? The already Dr. Christie is mentioned regarding MCU. What is the radiation issues there? Is it actually the first simple first UTA? They had supposed to do MCU also routinely?
Yes, actually, less than 1 year they recommend all the investigations, because the chance less than 1 year the chance of reflex nephropathy is more. Less than 1 year UTI, the reflex nephropathy chance is very high. So the IAP recommendation itself is less than 1 year. You do all the investigations, including ultrasonography, this DMSA and MCU. But more than 1 year, if the ultrasonography or DMSA is abnormal, we can go ahead with MCU. But less than 1 year, they recommend all the investigation. Even if there is a chance of radiation, they recommend all the 3 investigations.
So another question from is what to do if the midstream catch culture is not significant, less than 1 lakh, roughly say 50,000.
Yeah.
Single organism, whether it's you had to take it as serious or you had to you can ignore it.
But actually, by definition, by the culture positivity means, as I already mentioned, the suprapubic culture, we can have any number of culture. We can call it as a significant bacteriuria. And if there is a less than 1 lakh, this 10⁵, 1 lakh colony count, we can repeat a culture, or we can take a suprapubic culture or catheterized sample. So we can confirm the diagnosis. So if less than, by definition, we cannot label it as a urinary tract infection, because it can be a contamination also. Even if it is a single organism, it can be a contamination also. So by definition, we have to repeat the culture. Again it's less than, colony count is less than this 10⁵, we should do a suprapubic aspiration to confirm the diagnosis, because we are putting the child on a continuous prophylaxis after that. Based on this culture, till the imaging studies are completed, we are putting the child on a long-term prophylactic antibiotic, so that the diagnosis should be correct. That is very important.
Okay, thank you, Harish. And whether you had to. Christy, madam.
Joseph, I would like to. I would like to add one point. Here the question is 5 into 10⁴. The Indian guidelines say into 10⁵. Since it is 5 into 10⁴, it is the cutoff for European guideline. So accepting that, you can accept it as UTA. So it has the European guidelines are accepted that criteria based on some evidence. So since it is 5 into 10⁴, we can accept as UTA. If it is 10⁴, it is 10⁵, we have to follow what Dr. Harish has already said.
Okay, thank you, Dr. Christy. Is any role already Dr. Harish is, I think, mentioned whether role of any repeat culture end of treatment UTA? Is it role?
Yes. No, actually, repeat culture is not needed. Repeat culture is not needed at the end of UTA, because if there is a very good clinical response, we should not do a repeat culture after treating the UTA.
Okay, thank you. And Dr. Preja is mentioned, is the infant present with UTA after 1 episode of diarrhea, should we do all the MCU and DMSA?
Okay. Infant.
Less than 1 year.
Less than 1 year. Dr. Christy, what is your opinion?
Actually, biologically, what we think is like UTI will increase, the VUR will increase the UTI, and if you give antibiotic prophylaxis, it will prevent the pyelonephritis and it will prevent the scar. That's why we are working up for VUR and by doing this MCU. But what evidence has shown is that the presence of the VUR, the scars may be due to some dysplasia, and the long-term studies of antibiotic prophylaxis in VUR has not shown to decrease the incidence of pyelonephritis, or it has not shown to decrease the scar. So our aim by doing an MCU is to find a VUR and to decide whether to initiate an antibiotic or not. So if the evidence is not sure, so why should we do an MCU? So as per the current guidelines, the answer to your question is we should do both. But the evidence that has the guideline came in 2011. So the evidences which has come after 2011 questions this this approach. So the next guideline will come either in 2022 or 23, the Indian guidelines. So we are anticipating a change in this guideline. So the answer is the guideline. It is we should do if we are agreeing with the evidences, we shouldn't do. We should do an ultrasonography. If there is dilatation, you should go ahead with workup.
So what is Dr. Harish, what is the role of what is the plan of asymptomatic bacteria? Have to treat it or not?
Sir?
Asymptomatic bacteria.
Okay, symptomatic bacteria, actually, we should, if it is a non-E. coli or a fungi, we should treat. Or if the asymptomatic bacteria without any symptoms, that is without any complicated symptoms like urinary tract obstruction or VUR, we don't have to treat. Asymptomatic bacteria warrants no treatment. Especially only in some situations we need a treatment, especially in urinary tract abnormalities, in adults is a pregnancy, all these conditions, even if it is an asymptomatic bacteria, we should treat. Otherwise, it doesn't warrant a treatment.
Another question is, how often imaging needed as follow-up case of a VUR till resolution? How often he had to do? I
already mentioned yearly 6 months to 1 year, yearly follow-up is needed. Yearly ultrasonography, or we can do a radionuclide cystography. So actually the anatomical details we will not get with a radionuclide scan, but ultrasonography we should do yearly till resolution, yearly.
How the bladder bowel dysfunction can be managed?
Actually, okay, bladder bowel dysfunction, actually, the cause of the bladder bowel dysfunction is, identifying the cause of the bladder bowel dysfunction is very important. So, first thing is that toilet training is the most important thing, because most of the bladder bowel dysfunction occurs due to the inappropriate toilet training. So toilet training, early toilet training is the most important thing to prevent a bladder bowel dysfunction. Then we should assess any neurological abnormalities. Also, we should assess like spina bifida and other neurological abnormalities should be also assessed. The detailed evaluation of the neurological assessment is also needed. So most important thing is the early toilet training at an appropriate age is the most important thing to prevent a bladder bowel dysfunction.
Thank you, Dr. Harish and Dr. Christy, for a beautiful presentation on the Kidney Day celebration. Already we are running short of time. Already it's now the 10:10. So I think it's a too long discussion. We had a beautiful discussion on two topics. Congratulations to Dr. Christy and Harish for a beautiful presentation. So thank you, IAP Kottayam, this opportunity to share this this topic on UTI in children. Thank you, Dr. Joseph Patani sir and Preecha and all the IAP members for giving opportunity. Thank you.
Thank you, sir. Thanks.
Thank you, sir. Finally, we will go to the vote of thanks. Okay, I would, on behalf of IAP Kottayam, I would like to thank our speakers, Dr. Christy Catherine, pediatric nephrologist, for taking a detailed overview, giving us a detailed overview of hydronephrosis and providing us an algorithm how to follow up both unilateral as well as bilateral hydronephrosis, and Dr. Harish for accepting our invitation. And actually, I would like to mention one thing, that we had decided on some other topic, but all of a sudden we had to change the topic, and within 36 hours, Dr. Harish prepared this UTI while on duty in his hospital. Special thanks to him for accepting to change the topic at the last moment. Thanks a lot. And it was really nice session. And even now, I think many participants will continue to listen to the thing. And I would like to thank Dr. Virendra Kumar sir, very senior faculty of Kottayam ICH, for coming and moderating the session. And the questions are very tough. I was like, ayyo, but it was very nice interactive session. Thank you, Joe sir, because you were very busy and I never thought you will accept that also, because you were in such a busy conference in Calicut, but you agreed and came to our program and moderated Dr. Harish, and it was very nice to accept our invitation. Thank you, sir. And I would like to thank all the senior faculty, senior teachers. Sulekha madam had joined from SAT Hospital, Trivandrum. That was actually a very big thing, although she didn't comment anything. And all the senior teachers of medical colleges, all senior doctors, consultants, all the dignitaries who joined today, I would like to thank each and every member. Thank you. Thank you, sir.
Thank you once again to all.
Danny sir, good night.